If we wait for another 1 and 2 minutes, let's see.
Sure.
Yeah.
Well, I must congratulate you for organizing these meetings on a Sunday morning. I don't think I could ever persuade any of my colleagues to meet on a Sunday morning.
Yeah, probably is the most convenient time for for us. More relaxed.
Right. I remember when I was a young consultant, Sunday mornings you had to do rounds. So, and then they changed things to a 5.5 day work week, where we only did rounds on Saturday mornings and had meetings. Then we've now changed to a 5 day work week, so nothing happens on weekends anymore.
So who does the rounds? No one?
Well,
The on-call.
only the on-call team goes
The
on rounds.
on-call.
I mean, I think in the past everybody went on round every
Yeah.
day because there were just too many patients.
Mm. No,
Right.
that happens with in our hospital as well. The on-call neurologist does the Sunday round, not the Saturday one, the Sunday one.
But yeah, things have changed. I don't think we can persuade any of our junior
No,
doctors and staff to turn up and do
no more.
rounds anymore. Uh, shame. I'm told that many Asian countries are now being forced to go on 4 day weeks because you have to save energy.
Oh.
Yeah, I heard it in Sri Lanka and in Pakistan and in Bangladesh. Obviously India's got more energy resources, but they've had to go on 4 day weeks, poor things.
This is after the war or before
Yes,
the
yes,
war?
after
After the war. Okay. Oh, wow.
There's petrol rationing in Sri Lanka.
Mm. Yeah, many years ago, we were used to mud ovens. So we'll probably start the mud ovens now again.
What's a mud oven?
The mud, I don't know.
Oh, mud oven. Sorry.
The mud
Oh, right.
ovens.
Yes.
We go prehistoric. It works, no problem.
Well, I have to say that I changed to an electric vehicle a year ago, and so I have no idea what the petrol price is, but I'm sure they're going to raise the price of electricity as well.
Yeah, it's going up. It's going up here as well. It has to. I mean, and this is going to be a bit later. We will see more of that because now the reserves are still there. Each country has their own reserves.
Yeah, I think this is going to be a big push towards renewable energy.
Yes.
Visiting my parents in Malaysia, they have solar, and and I was amazed because we had a power outage, and so then my sister said, "Don't worry," and she plugged the house, the refrigerator and the toaster and everything into the car battery.
Oh.
Yes, so the car battery, got us our breakfast and kept the refrigerator going, and not the air conditioning, but it was early in the morning, so it didn't matter. And much to my surprise, after 3 hours, only 1% of the car battery had been expended. So,
wow.
Yeah, two things I reflect on. One, the cost in energy of driving a car around is so much more than just keeping your house going. It's ridiculous, actually.
Very true.
Yes, it's ridiculous. And now you can use your car as an energy supply.
Wow. That's great news. Very helpful news for all of us. Thank your sister for that.
I was very surprised. Just say,
Well,
your car can charge your home.
Should we start, sir?
No,
Fine.
Shweta will give a go ahead and
Shweta?
then.
I think I see 27.
Yes, yes. So
Please start, man.
Okay.
Thank you.
Good morning.
Morning.
So good morning to all of you who have come, and I'm sure some more will turn up. I know it's a Sunday morning, but we have a great program again for you on behalf of the subsection, Cognitive Neurology subsection of the Indian Academy of Neurology. I am Dr. Amitabh Ghosh, and with me is Dr. Suman Kushwaha, and we have a I don't know how to describe, a wonderful, a great um, speaker today, Dr. Christopher Chin, and Dr. Suman Kushwaha will be introducing Dr. Chen to you, and we're expecting a super talk really on anti-amyloid therapy. Dr. Suman.
Good morning, all, and it gives me immense pleasure to introduce Professor Chen, who is a senior clinician scientist at Yo Lo Lin School of Medicine, National University of Singapore. His research training was at Oxford University and Institute of Queen's Square, London. His major interests are in biomarkers and neuroimaging and treatment of stroke and dementia. He has over 500 publications and leads up multiple studies and clinical trials, including the Clarity trial, which we will be discussing today. And his aim is to build the regional collaboration in brain health, and his role as the president of Asian Society Against Dementia and Asian Oceanian Association of Neurology. So, as we all know, we are all excited about the new drug therapy which is coming up, anti-amyloid therapy. So, this topic today, preparedness of anti-amyloid therapy, the Asian perspective, will give us a lot of answers. So, once again, warm welcome to Dr. Christopher Chen, and please start your lecture.
Thank you very much. I'm very grateful to the chairs and to the Indian Academy of Neurology for inviting me to share my perspectives on how we prepare for anti-amyloid treatment. I hope my slide are up.
Yes.
Yeah, it's
Yes.
visible.
Okay. So as mentioned, I'm from the Memory Aging and Cognition Center at the National University of Singapore. And I'm funded by the university and the National Medical Research Council to do both clinical as well as research activities focusing on cognitive impairment and dementia. So here are my conflicts of interest. I receive funding from the NMRC as from various commercial entities, and I'm advisory board member for a number of companies. So a quick introduction to the Memory, Aging, and Cognition Center. This was set up over a decade ago to focus on what we call an Asian phenotype of dementia and cognitive impairment due to both neurodegeneration and cerebrovascular disease. And we collaborate with both institutions and research centers in Singapore and internationally. And our focus is not only on blood biomarker discovery and mechanism of disease, but also advancing the use of neuroimaging as biomarkers and diagnostic tools, as well as performing clinical trials and researching into clinical and neuropsychological aspects and community-based aspects of cognitive impairment and dementia. And we've been fortunate to be funded by the National Medical Research Council over the years. And in addition to clinical trials, we also do a number of observational studies. And I think that we would be really excited to be collaborating with India in the future on looking at characteristics of cognitive impairment and dementia, both in memory clinic populations as well as in community populations, using a number of platforms such as blood biomarkers, neuroimaging, and also, interestingly, retinal and cardiac imaging. But really, the focus today is on clinical trials. So we have a lot of expertise on this, not just in doing industry-based clinical trials, but also academic industry partnerships and investigator-initiated trials. So suffice to say that the bulk of today's talk will be about anti-amyloid therapies, and we have taken part in a number of these trials. In particular, the Clarity trial, which will come up later. So why are we so focused on anti-amyloid treatments? I think that all of us know that neurofibrillary plaques and tangles, sorry, what am I talking about? Neuritic plaques and neurofibrillary tangles are the hallmarks of Alzheimer's disease. These were what Alois Alzheimer discovered in the brain of the first patient he looked at, August Dieter, using advanced silver stains to see plaques and tangles. We can now visualize them using immunocytochemistry as well. And we have, over the last couple of years, come up with a amyloid-based hypothesis for the pathogenesis of Alzheimer's disease. And that many lines of evidence suggest that we should be focusing on amyloid because genetic risk factors, environmental risk factors, etc., seem to go and lead to an increase in amyloid, which then subsequently leads to tangles and neurodegeneration and the clinical features of Alzheimer's disease. Amyloid has been shown to accumulate in areas of high metabolic activity, and then it spreads to other cortical areas and finally reaches the brainstem and cerebellum. This is in contrast with the accumulation of tau, which is almost exactly the opposite. Nevertheless, we are very convinced that amyloid plays an enormously important factor in Alzheimer's disease, as evidenced by the genes which cause early onset Alzheimer's disease. And these genes seem to be linked to amyloid directly. And even in late onset sporadic Alzheimer's disease, many of the genetic factors are also linked to A beta homeostasis. Now, furthermore, many studies have shown that amyloid is an upstream event in Alzheimer's disease. It seems to be a trigger or driver for the development of Alzheimer's disease, and that tau is downstream of amyloid. But tau seems to have a very important direct effect on neurodegeneration. So these two pathological hallmarks are intertwined, but amyloid seems to come first. Therefore, the first generation of disease-modifying treatments really focus on amyloid. And just in case you weren't already aware, a disease-modifying treatment, as opposed to a symptomatic treatment, focuses on delaying or slowing the progression of disease by targeting the underlying cause. We have, in the treatment of Alzheimer's disease, really been focused on the use of symptomatic treatments. But these, unfortunately, do not really change the trajectory of the disease. And of course, many of us are aware that in other fields of medicine, such as rheumatoid arthritis, etc., disease-modifying medications have revolutionized treatment. And in neurology, we all have experience with multiple sclerosis and recently with migraine to show that disease-modifying treatments can really make a difference for our patients. So what are the different types of antibodies which have been looked at in Alzheimer's disease? They vary a lot, and it's very important to understand that they target different species of amyloid, ranging from those which look at A beta monomers to those which target oligomers, protofibrils, and even the plaques. Suffice to say that the successful anti-amyloid therapies appear to be those which focus on the later, perhaps more toxic stages of amyloid. As I mentioned, we're going to focus on the results of Clarity AD because this was really the first study which clearly showed that there was a benefit from such disease-modifying treatment. And we were very privileged to have taken part in this study, both in Singapore, Japan, and in Korea. So as you can see here, the Clarity trial included about 17% of Asian patients. Again, as I said, mainly from East Asia. But this is a very diverse global trial. the trial was able to show quite clearly that it had a significant effect on amyloid as measured by amyloid PET. Lecanemab reduced amyloid burden at all time points, beginning at 3 months. And you can see that actually it virtually eliminated amyloid. In other words, most patients had a PET scan which was indistinguishable from normal patients by 12 to 18 months, which is really a remarkable result. This is really akin, for example, from our oncology colleagues saying that they have drugs which can eliminate any trace of the tumor. In terms of clinical efficacy, lecanemab also showed that it was significantly effective in slowing disease progression. Using a measure called the CDR sum of boxes, the rate of progression was slowed by 27% by 18 months, and in fact showed a significant difference beginning at 6 months. And the difference seems to be diverging. Now, most of us are not familiar with the CDR sum of boxes because we don't use it clinically. Suffice to say that most patients, because they were early in the disease, they were either MCI or early Alzheimer's disease, they had pretty low total CDR sum of boxes. As you can see here in the little box on the right, if you have a CDR global score of 0.5, i.e. MCI, your CDR sum of boxes is between 0.5 to 4. And if you have 1, it goes from 4.5 to 9. Of course, it goes up when you have more severe dementia. But this difference in the CDR sum of boxes was a significant difference when you look at the total CDR sum of boxes scores in these patients. Moreover, when you look at the CDR global, which is a much more compressed score where CDR 0 is normal, 0.5 is questionable dementia or MCI, CDR 1 is mild dementia, CDR 2 is moderate dementia, CDR 3 is severe dementia. There's also a significant lowering of the risk for converting to the next stage of disease as measured by CDR global, a 31% lower risk, which is, I'm sure all of us would agree, clinically significant and really meaningful. Of course, there were side effects, and the ones that we're more worried about are what we call ARIA, amyloid treatment-related imaging abnormalities, and they come in two flavors. There's amyloid E, which is the American way of spelling edema. So ARIA E shows up on MRI scans as patches of T2 or flare hyperintensity, as shown by that arrow in the picture on the top right corner. And we know that the risk of amyloid E is increased by ApoE4 genotype, particularly if you are ApoE4 homozygous. Nevertheless, it's important to note that the vast majority of ARIA-E were asymptomatic. ARIA-H is ARIA hemorrhage, and again, it seems to be increased by your ApoE4 genotype. It is increased in ApoE4 homozygotes. And the timing of these lesions, ARIA-E and ARIA-H, mostly occur in the first 6 months of treatment. And I think it's important to appreciate that isolated ARIA-H, which is mainly microhemorrhages, seems to occur randomly across the clinical course, but ARIA-H that occurs together with ARIA-E is early in the course of treatment. And it would probably make more sense, clinical sense, to focus on ARIA-H that occurs with ARIA-E rather than isolated ARIA-H, which I think many of us who do MRI scans on our patients know is quite common. Another piece of interesting news is because the Clarity trial contained 17% of Asian patients, it was possible to do a sub-study of these patients. And the interesting fact is that it would appear that the incidence of infusion-related reactions of ARIA-E and ARIA-H was about half in the Asian population as compared to the rest of the world. And I think that many real-world studies, in particular a recent paper just published in the past week from Japan, shows that in their experience of over 2,000 patients, these lower side effect rates are also present in the real world, not just in clinical trials. So to conclude, lecanemab gave us a lot more clarity than the earlier treatments. And it was approved by the FDA in July 2023, approved in Asia, in Japan first, in China, and then in many other countries last year. And I believe it's still undergoing approval process in India. But of course, lecanemab is not the only anti-amyloid therapy to have been approved. The donanemab studies run by Lilly also showed a significant reduction in amyloid, and they also showed a significant slowing in the rate of progression of disease as measured by the CDR sum of boxes. And there are two graphs here because it shows that there seems to be a better performance in those who have low to medium tau as compared to those with high tau. So again, you can see that both amyloid and tau are related, and it might suggest that picking patients or treating patients at an earlier stage of disease where they only have amyloid but no significant tau is very important. So donanemab confirmed that there was a class effect of anti-amyloid treatment and also was approved by the FDA, and I understand is also soon coming to India. Now, of course, having these new drugs means that we need to prepare ourselves for implementing the results of these clinical trials. And as disease-modifying treatments for early Alzheimer's disease receive approval, and these two will not be the only ones, our healthcare systems need to really look at our capacity to detect and diagnose early Alzheimer's effectively, because these treatments are only really effective so far for people with pretty early AD, in other words, either those with MCI or early dementia. And of course, this will enable us to give our patients and their caregivers timely clinical treatment. But of course, as an increasing number of people know about these treatments and they come to seek diagnosis for their cognitive problems, our busy medical systems will face problems. There will be, even less time to examine people with cognitive assessments. There will be a great pressure on access to specialized diagnostic tests. And of course, many of our colleagues who are less well informed about dementia disorders may be facing issues when patients come to speak to them. These issues can delay referrals, they can impact on diagnostic accuracy, and of course affect the timeliness of treatment. Now, we recognize that these challenges existed, so a group of colleagues across Asia met and put together a framework for best practices and readiness in the advent of anti-amyloid treatments. So we proposed this framework in order to provide practical guidance to prepare for the administration of anti-amyloid therapies, to identify challenges to the introduction of these new therapies, and also, of course, highlight future directions to support the optimal use of these therapies. Now, although we came from across Asia, given the diverse healthcare infrastructure and resource availabilities in different countries in Asia, these frameworks, of course, must be adapted to local settings. And therefore, it's incumbent on all of us in our different cities and states and countries to go and think about this carefully. This is a quick summary of what we recommended. So we suggested that it was very important to establish workflows and protocols to enable the early identification assessment for eligibility to these accessing these treatments. And we gave 5 solutions. Firstly, of course, we had to improve diagnostic protocols and infrastructure. We had to put in an infusion protocol because currently these drugs are only delivered by infusions. We had to put in a system for monitoring, identifying, and managing ARIA and other adverse events. We had to develop cross-disciplinary collaboration because without this, no single clinician can do this all by themselves. And of course, we had to focus on education, not just for clinical colleagues, but also for patients and caregivers. And we feel that this framework can help us deliver anti-amyloid therapy safely and efficiently. And of course, hopefully, this will enable us to encourage adaptations for our healthcare systems when more data arises. So just to reiterate, we recognize that there are a number of challenges to Alzheimer's disease treatment and care. We recognize that current clinical practices mostly revolve around symptomatic treatments. Many people are not aware and not prepared to give disease-modifying treatment. We also recognize that because there wasn't disease-modifying treatment in the past, we have not really used diagnostic testing early, and this leads to late-stage diagnosis. Moreover, the cost and resource constraints revolving around diagnostic tests lead to relatively low utilization of the advanced technology that is needed to deliver effective and safe anti-amyloid treatment. Moreover, there's a huge variation in the degree of testing being done on patients across Asia. But given this new impetus for the use of anti-amyloid treatments, we really have to go and face up to these challenges. And again, a group of us have put together our thoughts on what we're going to do about early diagnosis of, say, mild cognitive impairment due to Alzheimer's disease. And we highlighted several challenges that we all share. Firstly, MCI is a neuropsychological construct, and many of us lack the neuropsychological test batteries or access to trained neuropsychologists to be able to perform comprehensive tests. And many of us do not have access to amyloid PET or to CSF lumbar punctures to diagnose Alzheimer's disease using biomarkers. In most countries across Asia, apart from perhaps Japan and Korea, detection of MCI due to AD was considered suboptimal due to low disease awareness. And there were many barriers to assessment, including lack of access to healthcare visitors, lack of access to neuroimaging, etc., etc. Nevertheless, we know that early diagnosis has many benefits, even without the advent of anti-amyloid treatment. It enables us to identify and treat reversible factors. It, of course, now enables us to treat people within the optimal therapeutic window in order to slow disease progression. And I think it really has a big benefit for our patients. So to begin with, the first pillar of our framework is that we need to improve diagnostic protocols and infrastructure and also capacity. We have to bear in mind that we cannot take shortcuts. Patient eligibility should be strictly based on the approved label for anti-amyloid treatment. And they therefore must have a diagnosis not just based on the clinical features, but also on biomarker positivity. So we have to make diagnostic tools available. And we'll cover that later in more detail. But as you know, we don't only have PET imaging and CSF analysis, but there's the emerging role of blood biomarkers. But we have to build the infrastructure. So these facilities for molecular imaging, CSF analysis, blood biomarkers, and genetic testing have to be built up. And we have to have staff who are expert to conduct these evaluations. We need dementia specialists, we need geneticists, neuroradiologists, psychiatrists, psychologists, paramedics, etc. So these are our currently used gold standard AD biomarkers, amyloid PET and CSF. But they're expensive and they're invasive. So many centers don't have access and many patients don't want to have CSF lump punctures done for CSF. But I think that the situation is changing. I remember coming to India last month, and suddenly from having no PET amyloid, it turned out that actually these were being made available. And of course, CSF lumbar puncture is something that all of us neurologists are happy to do. But what about blood biomarkers? Here's a review from my colleagues showing that there's now an array of new technologies which have vastly improved sensitivity compared to conventional assays for different types of amyloid species, and these may be very relevant to Alzheimer's pathology. Only a few years ago, we were able to show that the plasma p-tau 181 to A-beta 42 ratio was pretty good at detecting amyloid PET positivity. But as you can see here, we only achieved an AUC of 0.89. Now, that seemed pretty good, but it's not good enough. And in fact, the level that has been set by the Group CEO Initiative on Alzheimer's Disease says that for a blood biomarker to be used as a triaging test, it should have a sensitivity of equal to or above 90% and a specificity of between 75 to 85% to be a triaging test. But if it's going to have a be used as a confirmatory test, you really need sensitivity and specificities of above 90%. And as you could see from before, we didn't quite reach 90%. But this changed early in 2024, where colleagues were able to show that a new biomarker called p-tau 217 achieved really remarkable sensitivity and specificity for detecting not just amyloid, but also tau. And they showed that this performance was equivalent to the CSF biomarkers. So that's fantastic. So we now have p-tau 217, and some of you may realize that p-tau 217 A-beta 42 ratio has been licensed for use by the FDA using the Fujiri Bio platform, and I believe that platform is available in India through another company. This has led to the Alzheimer's Disease Association work group recommending that perhaps the time has come for blood biomarkers to play a role in the diagnosis of Alzheimer's disease. But its widespread utility has been hindered by several factors. Firstly, not all of us have access to commercially available assays, and it's a real bother to be able to set up your own research setup. But as mentioned, commercially available assays are available now, and many more are coming along. But the second and more urgent problem to solve is whether these biomarkers, which were validated in other populations, particularly Caucasian populations, are they valid in local populations, particularly Asian populations? And finally, of course, whether they have regulatory approval for use in your country and whether it's reimbursable. So what we have done in Singapore is that we have validated the use of the Quantrix p-tau 217 assay in our local population against the gold standard of amyloid PET. And we have shown that the cutoff points are very equivalent to what was found in Western populations, even though our patients had a high prevalence of concomitant cerebrovascular disease. So this is very reassuring, but of course, it may need to be repeated in other countries. And this is ongoing now, and there are studies already in South Korea, Taiwan, and Japan. And I am sure that studies should be done in India. So I think the potential future landscape of diagnostic biomarkers will start off with blood biomarkers as a first-line biomarker, use MRI and CSF and PET scans as both rule-out biomarkers, because we know that we shouldn't include people who have significant cerebrovascular disease, tumors, etc. And lumbar puncture and amyloid PET scan may still be the gold standard for the foreseeable future. Now, what about infusion protocols and infrastructure? The therapy infusions, as we know, are administered over an hour between every 2 to 4 weeks. And we need personnel to be able to administer this. And we need infrastructure to be able to provide our patients timely access. We need to make sure that these facilities exist and our patients are able to access them, and that the staff that run these centers are familiar with patients who have early Alzheimer's disease. Now, of course, many of us work in centers where infusion centers already exist because they are used to give infusions for chemotherapy, etc. But I think in many public hospitals, these infusion centers are very busy. The situation may be less acute in private care, and certainly in Singapore, we have done some private-public collaborations, and we're trying to build up our capacity. Other ways forward include having outpatient infusion centers, but perhaps this might be considered a little too early for anti-amyloid therapy, but this is something to think about in the future. And of course, home infusions, which can happen if we set up the necessary infrastructure. Monitoring, identifying, and managing ARIA and other adverse events is something that we can build up and must build up, because the safety of patients is paramount. But of course, the good news is that most ARIA is asymptomatic, and even if they're picked up, they can resolve with dose adjustment or withdrawal. There are several symptoms which are common for ARIA, including headache, confusion, vomiting, gait disturbance, visual disturbance, and we have to become familiar with that. And not only the treating physician, but also primary care and ER. We need to be aware, and patients need to be counseled on what the risk factors are. These include your ApoE status, whether you've had an MRI scan showing evidence of microhemorrhages, etc., how much treatment you've gotten. So, for example, you may be aware that the titration regime for the donanemab has been changed, and this has been shown to reduce the number of ARIA, and perhaps the use of antithrombotics and anticoagulants. But we need to train our personnel, and we need to establish an infrastructure. The recommendations of ARIA include having routine brain MRI. So this is a very important point. We cannot give treatment to patients who cannot tolerate MRIs, because they need a baseline and they need regular MRIs for safety purposes. And there are, fortunately, rules about what we do with ARIA. So asymptomatic mild ARIA, you don't have to stop. You just have to continue monitoring. If you're asymptomatic moderate ARIA, dosing can be suspended and can be restarted if serial MRI shows resolution of the ARIA. But of course, we stop out of caution if you have severe symptomatic or recurrent ARIA. Optimizing interdisciplinary collaboration is so important. Not only to enable diagnosis, because we need our PCPs and our general colleagues to evaluate subjects and refer early so that we can, as specialists, treat within this optimal referral window, but also in order that treatment and disease management can be optimized. Because if we don't identify um, our patients who have ARIA or symptoms of ARIA, we cannot assure their safety. We need to educate medical professionals, which include general physicians, primary care practitioners, to better identify patients who have cognitive complaints and refer on. We also need to educate patients and caregivers that new treatments are now available. Our colleagues as general neurologists, geriatricians, and psychiatrists who may not want to give this treatment should be able to understand how to assess cognitive complaints and use cognitive assessment tools. We as dementia specialists need to become familiar with the efficacy and safety data for anti-amyloid therapies to identify and manage ARIA, to identify infusion reactions, to lead the establishment of protocols and care pathways for therapy, delivery, as well as safety. And of course, we need to work very closely with our neuroradiologists because they could be so essential for identifying and diagnosing ARIA. We can't ignore the need to educate patients and caregivers. They need to understand why monitoring is necessary. And this is really to prevent or mitigate potential adverse events. They need to understand what are the risk factors and why some patients cannot be given these treatments safely. And they really need to understand why we're doing these MRI scans. So a recent paper that we have just published in the past month addresses many of the issues that we perhaps need to discuss with our patients before we start therapy. And this paper on the clinical meaningfulness of anti-amyloid therapies recognizes that, unfortunately, whilst the topic is important, we lack data on Asian populations. And of course, particularly from the perspective of patients and caregivers. So we need to really collect this evidence. The challenge, of course, is that having a holistic approach to meaningful benefit means that we can't use just any single outcome. We need to be able to put together the sensitive outcome measures that have assessed effectiveness in clinical trials. We need to go and sort of give ourselves an understanding of what are the underlying biological and clinical factors. We need to take into consideration the perspective of different stakeholders. And of course, we need to identify what are really clinically relevant landmarks that are applicable in real-world settings. So I think that most of us who work on patients with cognitive impairment and dementia know that there is a continuum of symptoms, and patients progress along this continuum from having no symptoms to very mild symptoms to more significant symptoms. And that we need to be able to communicate with our patients what this means for them, that there may be subtle changes to begin with, and then more noticeable changes, and there may be ability to maintain some of your function to losing most of your function, and there may be behavioral issues which start off in a non-specific way but may become much more troublesome. Now, as clinicians, we need to understand what the various tools that have been used in clinical trials really measure. And I'm not going to go into this in detail, just to show that there are a number of tools which have been used, and they don't all measure the same thing. Nevertheless, we can, I think, rely on the CDR. As I mentioned before, the change from CDR global stage 0.5 to 1 to 2 is really very clinically significant. And all of us, and patients as well, and caregivers, understand that it's a big difference from having consistent forgetfulness to having much more noticeable forgetfulness, which affects daily activities, to having a terrible situation where there's severe memory loss. And there's also a big difference when there's only very slight impairment in your activities, daily living, your ability to take part in community affairs, to being unable to function independently, to being unable to function outside the home. So these are clinical landmarks. Moreover, we have to recognize that although sometimes we speak a different language, the top outcomes shared between clinicians and care partners and healthcare professionals are often um, very familiar. Most people are worried about their mental health and their memory. They're worried about activity, daily living, and they're worried about autonomy and maintenance of their identity. So we need to focus on these when we communicate the importance of these treatments to our patients. So in the paper that I said that we put out, we suggested using, simple tools such as having a chart which asks you to identify your top concerns about being diagnosed and what are the goals you want to achieve over time. I think it's very important that we should only give these treatments to people who have something to look forward to. I think that if you are just content to stay at home and watch videos, these treatments may not be the most appropriate way to improve quality of life. And we suggested using these kind of simple charts to identify what are the benefits of treatment, living longer, living better, having a combination of living longer and living better may be very useful in clinic. One way of explaining what the clinical benefit might be is based on saving of time. And of course, theoretically, we can say, oh, this can save you 3 months over 12 months, 9 months over 36 months, etc. But I find it actually very difficult to explain to patients what this means. And in the paper, we have suggested using these kind of cartoons, these kind of figures to show, for example, on the top left, what is the difference between symptomatic treatments and disease-modifying treatments. On the top right, what is the difference between what we saw in clinical trials and what has been suggested to be the benefit in open label extension studies. And of course, what is the time that can be saved on this treatment? So to conclude, I think that we can prepare for the advent of disease-modifying treatments because we have a number of solutions which has worked in other countries already and will certainly, I think, work in the Indian context. We need to improve how to identify patients with symptoms of early Alzheimer's disease in the community. We need to be able to determine whether the patient is eligible for anti-amyloid treatment by improved diagnosis, by improving access to diagnosis. We need to establish cross-disciplinary collaborations to enable us to diagnose, to monitor, and to treat, as well as to identify and manage ARIA. And of course, we need the infrastructure to deliver these infusions of anti-amyloid therapies in eligible patients. So the key takeaways are that we can prepare ourselves for anti-amyloid treatments. These treatments are already here. Even though we have a diversity of healthcare systems across Asia, we will have a diversity of solutions. So we need to expand our diagnostic capacity. We need to increase our infusion capacity. We need to expand our dementia care workforce by supporting cross-disciplinary training. And we need to educate our patients on what are the goals of treatment, what the expectations can be, potential harms, and the requirements for treatment. So I just end by saying that this is the future we envisage. And this is something that we came up with a few years ago. Not only are we going to improve treatments in tertiary care, but I think that we will really use our advanced technology to improve symptom detection and assessment in primary care, and hopefully to actually intervene before symptoms develop in the community. Thank you very much for your attention.
Thank you very much. Suman, you there? Yeah.
Yeah.
Do we have
Thank
any questions or any comments?
I think we don't have any questions in the chat box because in India, as we all know, we are just struggling to have these drug and the infrastructure. And this is a very great lecture in which at least we are able to understand the roadmap, how we have to improve upon the challenges which we are having. The first of the challenge is basically to diagnose the patient in the very earliest stage, that is NCI and early AD. We still are lacking in understanding, especially sensitizing the general physicians to send the patient to the neurologist, where we can have a cohort of those patients whom we can actually extend the treatment. So the first challenge which we will be actually having is to have a cohort of a patient of NCI in early AD. So there, what I assume that we have to do a lot of work with the general physicians and the neurologists to diagnose patient at the earliest stage. So this is the first of the, this is the major challenge what we will be having. And the other thing is, of course, the infrastructure and the availability of drug and the availability of biomarkers will be the other challenge, because we are still in process of availing these high-end biomarker testing in almost majority of the hospitals, still available in some of the private sectors and some of the centers only. So these are the two major challenges which we are seeing in our setup.
I
Dr.
think
Ghose?
before there's some questions are coming for Dr. Chen, but I have one after this wonderful talk. Don't know what to say, but thank you once again very much. Just a little practical question. It's interesting you said that the difference between an outpatient infusion versus an infusion center infusion. So the infusions you're giving in the infusion center, so how long are the patients staying there for?
About an hour, sir,
About an hour in the infusion center.
in the
And
infusion center. Of course, it takes them a bit of time to get prepared, but the
yeah,
infusion takes about an hour, and then we observe them for some time afterwards. But they don't have to be actually on a bed. They can just sitting outside.
okay. And the next question which follows is that when you have infusion-related reactions, how long after the infusion do you have them? Assuming they are not anaphylactic, the other ones, how long do you have? How long after infusion do you have them in general?
Well, I think in general it will be in the first hour or so after infusion. It is really very similar to all other infusion reactions to biologicals, and actually probably very similar to vaccines. So you know that whenever you get a vaccine, you're asked to sit down for 15, 20 minutes to see whether you develop chills, etc. So I think most infusions reactions are like that. And of course, in rare circumstances, they can occur within 24, over the next 24 hours. So really, you just need to make sure that your patient understands that if they don't feel well, come back.
Come back. Okay.
Yes.
Thank you very much.
But
So
maybe
we
I
have,
could just quickly respond to Dr. Suman's 2 points. And my
yeah.
suggestion is that, you know, I don't think you should have multiple people doing all this within one institution. I think you should form a group to run a dedicated memory clinic so that you can centralize your resources and your expertise. And I think that with it, if you set this up, referrals will come, expertise will grow, and it will be possible to go and sort of have the patients you want and the access to resources. I think it's very difficult for any individual to negotiate for PET scans, diagnostic tests, etc. But if there's a group of you, I hope that your voices will be stronger.
So we have one question by Dr. Murlidhar Reddy, and he is basically wanting to ask, do we have blood-based biomarker? No, not this actually. Your comment on having the region-specific data on blood and CSF biomarkers, will these cutoffs are different from that of the Western cutoffs?
A very good question. I don't know the answer to that because I hope they're not, but then again, they might be because these blood biomarkers can be affected by a variety of issues. So, for example, the known things include renal function, uh, prevalence of cardiovascular risk factors and disease, as well as body mass. So, um, they may be different. I certainly hope not.
Have you done the level in your country in Singapore? Do you have the cutoff of your own, or you are using what has been used in the Western population, Dr.
Okay,
Chen?
so as I showed in the paper that we have a published on the use of Quantrix p-tau 217, and those cutoffs are virtually identical to what was used. We're in the process of validating other biomarkers, and so we'll see what the results show. But I anticipate, just like any other um, blood test, you will have to have your own local standards. I'm quite sure that in India, you have your own cutoffs for, HbA1c, hyperlipidemia, etc. So it's incumbent on the regional local population, regional specialists to assure yourselves that you're actually making the right decisions.
Okay, the other question is, do we have the blood-based biomarker available in India? Yes, we do have the blood-based biomarker available in India from some private labs. You can go and check on them. And another question is,
So
I
could I,
think
could I
the
just
cost
make a
of,
comment on that, Dr. Suman?
yeah,
So blood-based biomarkers are already available in Singapore.
yeah, yeah.
But in general, I find that my patients aren't happy just having treatment based on blood biomarkers because the treatments are expensive. They are
Mhm,
onerous.
mhm.
I think they really want confirmation, and we have not had a single patient who said, I don't want amyloid PET, or failing that, I don't want CSF. I'll just go straight to treatment.
Yeah, that is actually very important because to know actually the amyloid pathology, either you have to show it in the CSF or on the amyloid imaging. These are the two
Probably.
methods. Yeah.
Probably. I mean, I can understand that eventually it may become acceptable to do it just based on clinical features and the blood
That is-
biomarker test. I think it's very important to emphasize you need blood biomarkers do not stand alone. They must be used only in the correct clinical context. So please don't go out and allow people to go and sort of test for blood biomarkers without any clinical features.
Yes,
Yeah.
I totally agree. If I can kind of reinforce and add that, Dr. Swayam Prakash, we are doing blood-based biomarkers, but we also do CSF biomarkers. And as Dr. Chen has said, that as of now, if you want to give either lecanemab or donanemab, it is a requirement that at least for now you do a CSF biomarker, which is kind of which is a requirement. As far as blood is biomarker, again, reinforcing the point that you have just heard, it entirely depends on your pre-test suspicion. How strong is your suspicion that this is going to be Alzheimer's disease? Otherwise, it simply becomes a triaging test, not
Yeah.
a confirmatory test. So I think that is something we all need to understand.
Yes.
Yeah.
I think it will take some time to establish blood-based biomarker alone as a test for giving the anti-amyloid therapy. It will take a lot of time, at least a year or so, because we are into doing the blood-based biomarker off late in India. So it will take time.
Yes,
And for
but
Other Asian countries as well, I guess.
I think it will come. And as Professor Ghosh has said, it will depend on the circumstance. So, for example, if you had a patient coming to you with typical history of Alzheimer's disease, slow progressive memory loss, etc., and this MRI scan shows nothing else to account for this, and may even show some atrophy,
Mhm.
then your blood biomarker test will have a really high positive predictive value. And if the patient says, I don't want to have a PET scan, I don't want to have CSF, I will go for treatment, I think that's reasonable.
Mm-hmm.
Conversely, if you have a patient who says he has some memory problems, but you can't find anything wrong, the cognitive testing is perfectly good, and the chances of them having Alzheimer's disease is quite low, doing the test and having a negative test has a very high negative predictive value. So that might be quite reassuring as well. So I think that's the direction it will go.
And another question, till what stage of the disease can we try these medications?
Okay.
Yeah, yeah.
Well, the clinical trials show that these treatments are only effective and safe for patients with MCI or mild dementia due to Alzheimer's disease. For people who are relatively asymptomatic and don't have MCI but have amyloid, trials are ongoing to show whether they are of benefit. So I wouldn't give such patients these medications until the trials show results. In terms of patients who have moderate or severe dementia, the earlier trials on anti-amyloid treatments were not very well, not good at all, actually, for such patients with advanced dementia. Now, you could argue that, these were trials done with other drugs, not the current drugs we're using. But I think it would be probably unwise and to start patients with moderate or severe dementia on these treatments, no matter how much the relatives begged you and, and how much pressure you're under. I think you really do need to draw the line because there's no evidence or efficacy of safety.
Mhm. And one question is, can we directly go for the ApoE gene bypassing the other tedious tests? Not at all, I guess.
Well, I hope you don't mean that clinical examination and MRI and etc. are tedious. I take it that the questioner wants to know whether the ApoE genotyping is sufficient to make a diagnosis and to show that the patient has amyloid. And unfortunately, um, the answer is no. Many patients who are ApoE4 heterozygous or homozygous do not develop Alzheimer's disease. They don't have amyloid. Many patients who are ApoE4 negative do get Alzheimer's disease. So it's not a good diagnostic test. I think that in this current context, the ApoE testing is only used for safety. It just basically informs you whether you are at increased risk of ARIA. It is not a diagnostic test.
Yeah. And another question which is already always been asked in all the meetings is regarding the cost of the therapy.
Oh, I'm not qualified to answer that because I'm only a doctor. I don't sell the drugs. But suffice to say that in Singapore, where it's not subsidized, it's a considerable cost. And many of our patients, unfortunately, cannot afford it. And we very much hope that the cost benefit analysis and will enable us to persuade the government to subsidize treatment.
Yeah. And the last question is, which cognitive assessment tool can be used to assess the treatment response? I think you have covered that in your lecture.
I didn't quite cover that. Of course, there's a difference between assessing clinically and
Yeah.
assessing clinical trials. So in clinical trials, we were given the resources and we used the tools like CDR Sum of Boxes, CDR Global. My practice has been that for clinical use, when we are now currently giving people anti-amyloid therapies, we use simple tools such as the MOCA MMSE, plus something called the QDRS, which is a questionnaire which asks the patient various questions about their cognition and function. And it's actually a pretty good tool to assess CDR global. So we're using clinically sensible tools to assess treatment response.
Great. I think we have covered the questions. Dr. Ghosh, your comments.
No, I think very good questions, and thank you for patiently answering them, Dr. Chen. And thank you once again for kind of uh, giving this lecture. It's always very helpful, and I learned many new things because we are also going to prepare for the anti-amyloid therapy. So the way you discussed that was very, very practical
That
and
will
very
be actually
useful.
very instrumental for all of
Very
us.
useful for
Go
us.
ahead.
Excellent. You know, I am so pleased to be with you today. These are really exciting times for us who deal with patients with cognitive impairment and dementia. You know, after years of not being able to offer people hope,
Yeah.
now we have. And you know, I have to say that I so enjoy seeing my patients on this treatment. They are better. It's. I'm glad I have come to this stage before I retire, and that this treatment is available for me in the future.
Oh no.
Yeah,
Yeah.
for many of us.
Yeah, for many
Yes,
of us, rather. Yeah.
absolutely, absolutely. I know we're not being entirely altruistic, but you know, we have to make these efforts to create the future.
Yeah.
Thank you.
Thank you.
Mm, no, there were no Indian patients included in these trials, I guess. In
Yes.
No,
clarity, no Indian patients. Yeah.
Well, no patients from India.
Indian
There may
countries,
have been
yes.
patients of Indian
Indian
ethnicity.
origin. Yeah.
Yeah,
Yeah,
but I think that there would be a very, very tiny number.
yes.
And I totally agree with Dr. Hassan. Uh, you will need your own data
Yeah.
and you need to follow up. But, you know, we're all human beings under our skins. So I don't think it'll be too different.
Mhm. Hmm. So, should we call for a day for
Yeah,
this?
yeah.
Thank you, Dr. Chan, once again
My
for
pleasure. My pleasure.
Thank you very
this
much.
interaction. And thank you, Dr. Ghosh. And at the end, I want to thank the digital team, Indian Academy of Neurology, for giving us an opportunity for this webinar. Thank you so much.
Thank
Thank
you.
you.
Thank you. Thank
Thank
you.
you. Bye-bye.
Thank you. Bye bye.
Bye.